We'll wait for 2-3 minutes. Live రాలేదు. చాలా లాగ్ ఉంది. అది వాళ్ళకి తెలియదు సార్. లైవ్ లో ఉన్న వాళ్ళకి తెలియదు. Hi everyone. I want to start the presentation. I'm Dr. Nikhil. I'm the Neonatologist at Cuddles, Visakhapatnam. Today we're going to discuss regarding non-invasive ventilation and high flow nasal cannula. I hope the presentation is shared. Today we're going to discuss regarding non-invasive ventilation and role of HFNC in our daily NICU practice. The main objectives of today's presentation are to understand different modes of non-invasive ventilation. What does the evidence suggest regarding the utility of various modes, bedside application of various modes and monitoring a child, and integrating care to our NICU in daily practice. So with these aspects, let us first look at two case scenarios. These are cases which we see routinely in our NICU practice. Case one, we have a preterm 26-weeker, 780-gram baby delivered by emergency LSCS. Was noted to have respiratory distress immediately after birth, was given delivery room CPAP and was shifted to NICU. In the NICU, baby needs to be started on non-invasive mode of ventilation. Since lectures on CPAP have already been finished, so CPAP, non-invasive ventilation is the primary mode of respiratory support, which is attempted before we go on to any mechanical ventilation. So in this scenario, what is the preferred mode of support for the baby? The options are nasal CPAP, NIPPV, that is non-invasive intermittent positive pressure ventilation, and high flow nasal cannula, that is HFNC. Similarly, case 2, we have a preterm 26-weeker 720-gram baby on mechanical ventilation since birth, currently on day 4 of life, and has been planned for extubation. So post extubation, immediately, what is the preferred mode of support that we would like to initiate in this baby? Again, 3 options among non-invasive ventilation are nasal CPAP, non-invasive positive pressure ventilation, and high flow nasal cannula. So let us go into the topic. Coming to non-invasive ventilation, the various types of non-invasive ventilation we can discuss are: one is constant pressure, constant airway pressure. The second modality is variable airway pressure. So in non-invasive ventilator support with constant airway pressure, we have 2 different ways by which we can deliver. That is through nasal cannula, through which we can deliver either a low flow non-invasive support or a high flow non-invasive support. Similarly, through CPAP, it can be a constant flow CPAP or a variable flow CPAP. In constant flow CPAP, we have conventional continuous positive airway pressure or bubble CPAP. Conventional CPAP is delivered through a ventilator. Coming to variable airway pressures Coming to modalities in which we have variable airway pressures, one option is NIPPV. In it, we have two types, that is synchronized and non-synchronized. The second modality is biphasic positive airway pressure. The third modality is nasal high flow nasal nasal cannula. So these are the different types of non-invasive ventilation that we have discussed. Just a word on CPAP, because it is the fundamental basis on which all non-invasive modes of ventilation are based on. Positive airway pressure applied to a spontaneously breathing infant throughout the respiratory cycle is what is continuous positive airway pressure. And the mechanism of action of CPAP is necessary for us to delve into non-invasive modes of ventilation. CPAP prevents collapse of alveoli with marginal stability, and thereby help in alveolar recruitment, which helps in maintenance of functional residual capacity. This FRC helps us in improving the VQ mismatch and reducing the intrapulmonary shunts, and increasing the alveolar surface area for gas exchange. Similarly, CPAP also stabilizes chest wall, thereby reducing airway resistance and reducing the work of breathing. It also splits an upper airway, through which it reduces obstructive apneas. CPAP also stretches lung pleura and upper airways, through which it stimulates the stretch receptors and thereby reduces mixed and central apneas. All these modalities together help in oxygenation and ventilation, and ultimately improve pH and reduce the work of breathing in a baby with respiratory distress. So how does NIV work? NIV is basically an extension of continuous positive airway pressure. So the basic mechanisms are similar. It reduces the upper airway resistance, stents smaller airways, and maintains chest wall stability, maintains surfactant function and prevents its degradation. It distends alveoli, increasing the alveolar surface area and improving gas exchange. It increases lung compliance through recruitment of marginally collapsed alveoli, and improves mean airway pressure. And through all these modalities, it increases functional residual capacity, reduces work of breathing, and ultimately improves gas exchange. Coming to the first mode of non-invasive ventilation, that is high flow nasal cannula. High flow nasal cannula is defined as delivery of heated humidified blended gas at flows greater than 1 liter per minute. The interface through which HFNC is delivered is through a binasal cannula, but the difference between the short binasal prongs and the binasal cannula used in HFNC is that the size of the prongs, it should be less than 50% of the nares, allowing for leak of gas around the cannula. Since there is no the setup, it is a single limb circuit carrying only inspiratory flow. As it is a single limb circuit with no additional method by which expiration can be enabled, the leak around the cannula allows the gas to diffuse out of the baby, and also the oral cavity acts as an valve through which the expiratory gases come out. Practical application, although HFNC is defined as flows greater than 1 liter per minute, routinely flows are initiated at 5 to 8 liters per minute, and as baby shows improvement, they are weaned gradually to flows of 2 liters per minute, after which it is stopped. So this is a setup. This is a picture demonstrating the HFNC circuit that is routinely used in NICUs. The first one is the HFNC through Fisher and Paykel, in which we can see an air oxygen blender along with an infant flow meter.
First slide here. Sir? షేర్ చేశాను సార్. షేర్ చేసాను సార్. ఫుల్ స్క్రీన్ ఆప్షన్.
Can someone confirm if the slides are visible? Are the slides visible?
మూవ్ చేయండి సార్. మూవ్ అవుతుంది. మూవ్ అవుతుంది. మూవ్ అవుతుంది. మూవ్ అవుతుంది.
Okay.
మూవ్ అవుతుంది సార్.
Okay. Sorry.
Objective non-invasive.
I am on the first slide now. What is being shown? Sorry for the technical glitch. There was, I think, a freeze in the slideshow. Briefly, the slides that I've discussed till now, I mentioned various modes of non-invasive ventilation, in which we find a constant airway pressure kind of non-invasive ventilation and variable airway pressure. Constant airway pressure is delivered through, can either be delivered through a nasal cannula, which can be a low flow nasal cannula or a high flow nasal cannula. It can also be CPAP, which can be either given through a constant flow. Constant flow CPAP can be given through a ventilator, which is called as conventional CPAP, or can be given through bubble CPAP. The variable flow CPAP devices use variable flow drivers through which variable flow CPAP is delivered. The other variety of non-invasive ventilation is variable airway pressure modes, in which we can see that the pressure delivered through the respiratory cycle varies between inspiration and expiration. In this, the three modalities are non-invasive positive pressure ventilation, that is NIPPV. This can either be synchronized or non-synchronized. The other modality is non-invasive nasal biphasic positive airway pressure. And the third variety is nasal high frequency nasal ventilation. Coming to CPAP, CPAP is positive pressure applied to a spontaneously breathing infant throughout the respiratory cycle. Understanding physiology of CPAP is necessary for us to understand the modalities of NIV as well. CPAP prevents alveolar collapse and thereby helps in recruitment. It maintains FRC. This FRC helps in improving the alveolar surface area for gas exchange and also improves PQ mismatch and reduces intrapulmonary shunt. CPAP stabilizes the chest wall, reduces airway resistance, and thereby reduces work of breathing. It also splints upper airways and thereby reduces obstructive apneas. CPAP stimulates the stretch receptors of lung pleura and upper airways and thereby prevents mixed and central apneas. Extrapolating the same mechanisms to non-invasive ventilation, during NIV, there is decrease in upper airway resistance. The smaller airways stenting occurs. NIV also helps in maintenance of surfactant function and prevents this degradation. NIV prevents collapse of marginally recruited alveoli and increases the surface area for gas exchange. It improves lung compliance and improves mean airway pressure. And through these modalities, it increases functional residual capacity and reduces work of breathing. And all these mechanisms altogether improve gas exchange. Coming to high flow nasal cannula, it is defined as a delivery of heated, humidified, blended gas at flows greater than 1 liter per minute through a binasal cannula. The cannula surface should be size should be less than 50% of the surface area of the nares, allowing a leak around cannula. The setup includes just an inspiratory limb carrying the inspiratory flow. So this leak around the cannula helps in exchange of gases in expiration, and the oral cavity also helps in washing out of expiratory air. Coming to practical application, HFNC is routinely initiated at a flows of 5 liters per minute and increased up to 8 liters per minute depending upon the requirement of the baby. Once we can find that there is improvement in state of the baby, it is gradually weaned and flows up to 2 liters per minute, after which HFNC is stopped. This is an image which is representative of the HFNC circuits that are routinely used in NICU. The first image shows an HFNC system from Fisher and Paykel, in which we can see an air oxygen blender with an infant flow meter. Flow meter has a flow readings from 1 to 12 to 15 liters per minute. We find there is a gas tubing connecting it to the pressure scaffolding, which is connected to the humidifier chamber and humidifier. Here, the gases that come from the blender are humidified and heated, and these gases go through the inspiratory limb into the nasal cannula, nasal interface, which is fixed onto the baby. The sizes that are in Fisher and Paykel system, the nasal cannula is called as OptiFlow, and various sizes are available based upon the weight brackets of the baby. While identifying the cannula which is to be used for a particular baby, one should see to it that there is adequate space for leak of gases around the nasal cannula. It should not be snugly fit, and there should be some gap between the nasal cannula and the columella. Coming to the mechanism of action of high flow nasal cannula, it acts on the principle. It acts on the following principles. It provides heated, humidified gas supply, which helps in reducing the work of breathing and reduces the stress on the major and minor airways by taking up the heating and humidification part. It also helps in washing out nasopharyngeal dead space. Variable degree of continuous descending pressure is seen because of the flow that is given through the nasal cannula. It also helps in CO2 elimination through washing out of the nasopharyngeal dead space. And through the above mechanisms, it also helps in reducing the work of breathing. So, understanding pressure delivery, the continuous descending pressure that is generated through the flows via high flow nasal cannula. This is a paper published in 2016 in which end expiratory esophageal pressure was monitored in neonates receiving high flow nasal cannula. End expiratory esophageal pressure acts as a surrogate of intrapleural pressure. It is seen that there is significant association between flow rate that is used in HFNC and end expiratory esophageal pressure. But with increasing flow rates, there is variability in end expiratory esophageal pressure. This is the graph. This is the picture that again shows this variability that is seen with increasing flows. As we can see, with flows of around 3 to 4 liters per minute, the end expiratory esophageal pressure varies between 4 to 5 or 4 to 6. But as we go up to 7 to 8 liters per minute flow, the pressures can even go up to 12 to 14 centimeters water. So this unchecked pressures can sometimes cause barotrauma to the lungs and cause air leaks. So one has to be conscious while using higher flow rates of around 7 to 8 liters. This is the table that again shows the range at a flow rate of 8 liters per minute. We can see that the pressure that is generated can vary between 6 to 15 centimeters water. Coming to NIPPV, NIPPV is a non-invasive application of additional positive airway pressure above baseline nasal CPAP at some added rate. So during NIPPV, what happens is, as in conventional mechanical ventilation, instead of providing a constant pressure throughout the respiratory cycle, we try to provide an additional positive inspiratory pressure for a fixed duration of time in the respiratory cycle, and then supplement it with a continuous descending pressure during the remaining part of the respiratory cycle. So the commonly used devices for NIPPV are one can use a ventilator for giving NIPPV, or there are dedicated NIPPV devices, but which are rarely used. The interface that is used for NIPPV is again nasal mask, short binasal prongs, or Ram's cannula. The same interfaces which are used for nasal CPAP are again used for NIPPV. Most of the experience with regards to NIPPV is with the use of nasal mask or short binasal prongs. Indications for NIPPV are, again, it can be used in situations as a primary support for respiratory distress syndrome, or in post-extubation scenarios. It can be used for babies who are having recurrent apneas. And whenever it can also be used in scenarios of CPAP failure before one goes ahead and starts the invasive ventilation. it can be used as a stepping a step above CPAP before going on to invasive ventilation. So why was NIPPV considered as a mode? Is mainly because of the following two reasons. One is CPAP failure. It is seen that nearly 45 to 60% of babies with respiratory distress syndrome on CPAP require mechanical ventilation, and 25 to 40% of babies on CPAP post extubation have extubation failures. And CPAP is not particularly useful in babies with poor respiratory drive. So in these scenarios, most of these babies used to end up being mechanically ventilated. But with mechanical ventilation, there is increased risk of various kinds of lung injury because of barotrauma, volutrauma, ventilator-induced lung injury. There is increased risk of ventilator-associated pneumonias, and it has been conclusively proven that each additional day of the baby being on mechanical ventilation, there is impairment of neurodevelopmental outcomes. So coming to NIPPV mechanism of action, as we have already discussed the basic tenets of non-invasive ventilation, the basic mechanisms, these mechanisms apply here as well. NIPPV, apart from the mechanisms as we have already seen in CPAP, it increases alveolar ventilation and minute volume because of the positive inspiratory pressure that is given during a brief part of the respiratory cycle. Because of this PIP that is given, the mean airway pressure is also increased and thereby helps in improving oxygenation. The PIP that is delivered during NIPPV also stimulates head's paradoxical reflex, thereby augmenting the respiratory drive. Head's paradoxical reflex states that whenever there is a prolonged duration of inspiration or a rapid gas flow that is seen in the upper airways of a neonate, it can lead to further augmentation of the respiratory drive and increase the duration of inspiration. So this is called as head's paradoxical reflex. So NIPPV stimulates the head's paradoxical reflex and improves ventilation. It also reduces obstructive and central apneas in neonates. So how does it do that? Is through this mechanism. In the pharynx, we have three regions. That's the nasopharynx, the oropharynx, and laryngopharynx. And the nasopharynx has two different group of muscles. That's the pharyngeal dilator muscles and the pharyngeal constrictor muscles. During spontaneous breathing, it is seen that even in neonates, whenever there is spontaneous breathing, there is activation of pharyngeal dilator muscles, thereby increasing the diameter of the nasopharynx, nasopharyngeal airway. This reduces the airway resistance and allows smooth entrainment of inspiratory gases into the trachea. And during expiration, there is activation of pharyngeal constrictor muscles and thereby ultimately having a synchronized breathing efforts. So NIPPV helps in stimulation of pharyngeal dilator muscles and thereby reducing inspiratory resistance. The high flow that is generated during the positive inspiratory pressure phase also helps in pressing soft palate against tongue and reducing leak of pressure. And the intermittent positive pressure breaths stimulates head's paradoxical reflex, as we have already discussed. So coming to the nobology of nobology while ventilating a baby on NIPPV. As in conventional ventilation, the same parameters are also used in NIPPV. We have PIP, positive inspiratory pressure, positive and expiratory pressure, inspiratory time, respiratory rate, and FiO2. PIP controls both oxygenation as well as ventilation. And whenever in post-extubation scenarios, we routinely use a PIP levels of 2 to 3 centimeters above the levels that were used in mechanical ventilation. While setting up of PEEP is important in mainly influencing the mean airway pressure, and it is titrated based upon the respiratory distress that is noted in the baby and the inflation that is seen on chest X-ray. The routine PEP parameters that are used during initiation of NIPPV are 6 to 7 centimeters of water. TI is usually set at 0.4 to 0.5 seconds. It is longer than what it is used in conventional mechanical ventilation. Longer TIs are used because of higher leak of inspiratory gases that are seen in NIPPV when compared to mechanical ventilation. Respiratory rate is again usually set at 35 to 45, and higher rates are in general avoided because of the increased leak that is seen and to provide sufficient time for each respiratory cycle. It is also titrated based on the PCO2 levels. FiO2 is titrated based on the saturations noted in the baby. NIPPV, while using as a primary in scenarios like primary support for respiratory distress syndrome or in post-extubation scenarios, the initial PIP is set at 18 to 20 centimeters of water with an initial PEP of 6 to 8 centimeters water. PIP, we can go up to 24 to 28 centimeters of water, although there are few practitioners, renowned practitioners who even advocate pressures of up to 34 to 38 centimeters of water. Although personally, we never use that high pressures. Inspiratory time is routinely set at 0.4 to 0.5 seconds. The higher inspiratory time is kept so because of the high amount of leak that is seen in NIPPV. The rate is kept between 30 to 45 breaths per minute based again upon the PO2 and the PCO2 levels in blood gases. We wean PIP initially during weaning of respiratory support. We first try to wean the PIP part to 14 to 16 and then gradually reduce the respiratory rate and then reduce to nasal CPAP once the mean airway pressure drops down to as little as 7 to 8 centimeters water. And the baby maintains adequate oxygenation on those parameters with normal blood gas and adequate hemodynamic perfusion parameters. Coming to variants of NIPPV, there are two different variants of NIPPV, that is synchronized NIPPV and non-synchronized NIPPV. By synchronized NIPPV, what we mean is that during each breath, the ventilator tries to synchronize the initiation of inspiration with the start of inspiration in the baby. There are 4 different triggering mechanisms that the ventilators use. The most commonly used trigger mechanism in India, at least, is the pressure sensing, in which the ventilator detects a change in the pressure noted within the ventilator tubings during baby's inspiratory efforts and thereby triggers the inspiratory breath. But the problem with pressure triggering is it's affected by leaks and it is ineffective in micropremies as they don't have sufficient muscle strength to generate changes in pressure in the ventilator circuit. The second mechanism that is available in Western countries, not available in India, is flow triggering, in which there is a flow sensor, mostly a hot wire anemometer, located between the nasal interface and the ventilator circuit. It detects the breath by the changes in flow within the respiratory circuit. Again, the problem with flow is it's affected by leaks and there is a chance of auto triggering. The latest method of triggering that is again available in market is the EADI, that is electrical activity of diaphragm. It is used in NAVA mode of ventilation, that is neurally adjusted ventilatory assist. This is physiologically better, but there is a requirement of respiratory effort to detect EADIs. This parameter is further discussed ahead in the presentation. The fourth parameter is Grasby capsule, in which a capsule is placed on the abdomen and movements of abdomen are identified again to note when the baby starts its inspiration. Coming to synchronized versus non-synchronized modes of NIPPV. Synchronized modes of NIPPV, the advantages include improved delivery of tidal volume. It reduces the work of breathing when compared to non-synchronized NIPPV. Probable reduction in complications like air leaks and gastric overdistension and lower fluctuation in tidal volumes. All of these advantages can indeed be seen even in trials that have been conducted assessing the utility of NIPPV, which we're going to discuss ahead. Now, coming to the fourth modality of non-invasive ventilation, that is high-frequency nasal ventilation. This is the non-invasive approach in which high-frequency pressure changes are added via any device to provide high-frequency modulations of flow. The same interfaces that are used for other modes of NIV, that is CPAP and NIPPV, are also used for nasal HFOV. The devices which can deliver these modes of ventilation are Drager BN series and SLE 6000. So the factors that affect ventilation and oxygenation in nasal HFOV are again the type of ventilator and the mechanism of ventilation that it uses. The frequency, although the optimum frequency that has to be set is unclear, routine studies, the exponents who use nasal HFOV routinely set frequency between 6 to 10 hertz. The third parameter is the inspiratory time, that is the IE ratio. IE ratios in general vary between 1:1 to 1:3. The most commonly used IE ratio is 1:2. The fourth parameter is the amplitude or the change in pressure. Change in pressure is in general kept as twice of the mean air pressure that is routinely used. The most important part that affects oxygenation and ventilation during nasal high frequency oscillative ventilation is the nasal interface. Since this is the part of the entire ventilator system that most strongly affects the exchange of gases, the highest resistance is seen at the nasal interface. So what interface is ideal for using nasal HFOV is still unclear. Although the modalities that are interfaces that are used are short binasal prongs or nasal mask or a nasal cannula, that's Ram's cannula. Again, there is another idea suggesting application of conventional breaths on top of oscillatory breaths. This helps in providing sigh reliefs. The frequency of sigh breaths can vary between 10 to 25. Again, there are no paradigms to allow us to understand if conventional breaths do provide additional benefit, and what if they do provide additional benefit, what number of breaths should be delivered and what settings are to be used. Again, coming to the limitations, as I have already discussed, it is not yet adequately studied in neonates. The parameters which are ideal for using in neonates for non-nasal ventilation are unknown. Ideal frequency, amplitude, and IE ratios are not determined. Limited data on patient safety is again a concern. Coming to nasal NAVA, NAVA is neurally adjusted ventilatory assist. This is again delivered through the conventional nasal interfaces that are used. Here, the trigger, instead of being pressure or flow changes in the ventilatory circuit, is the electrical activity of the diaphragm, that is EADI, eddies. The electrical activity of the diaphragm, the trigger is usually set at 0.5 microvolts. The limit in nasal NAVA is kept at, it depends upon the peak EADI during the respiratory cycle, and the NAVA level is usually set at 2 centimeters per microvolt. That is, for each microvolt of electrical activity that is generated by the diaphragm, 2 centimeters increase of PIP is seen, and cycling is done at 30% of peak EADI. The advantages are it is most physiological, with support determined by need of the need of the baby. Babies with increased respiratory distress tend to generate higher electrical activity of the diaphragm, and the higher electrical diaphragm would mandate the ventilator to deliver higher support during inspiration. So in this way, babies who require higher support will get that additional support from the ventilator. And synchrony is always achieved, since the latency between detection and delivery is least in NAVA mode. The disadvantages: placement of a catheter. For detection of electrical activity of the diaphragm, catheters are inserted into the esophagus, and they should be fixed at the level of insertion of the diaphragmatic crura. This requires expertise and experience, and there is frequent dislodgement of the catheter. It is not used in central apnea, as the primary principle of NAVA is the electrical activity that is to be generated in the diaphragm. In babies with central apneas in which there is no respiratory drive, NAVA fails to provide the respiratory support, and the problem is the limited availability. So a word on the nasal interfaces. So again, these parts would have been already dealt in detail in the prior classes. A short word, in the first image, we can see Ram's cannula. This is a nasal cannula with this is the modification of routinely used nasal cannula, but it has a wider bore and the prongs are relatively longer. And the material through which the Ram's cannula is made is stiffer. So the pressure delivery is again better in this kind of nasal cannula. The second image is fission vehicle short binasal prongs. The third image is the nasal mask, and the fourth is the optiflow. Optiflow is used for delivery of HFNC. Studies have evaluated the benefit of short binasal prongs over nasal mask, and they have shown that nasal mask tends to produce lesser nasal injury when compared to short binasal prongs, and the failure rates are similar in both scenarios. So in our unit, we routinely prefer using nasal mask when in preference to short binasal prongs. So a few slides on the evidence regarding the various modalities that we have just discussed. Primary support for RDS in a preterm neonate. As we have been discussing over the past few sessions, nasal CPAP is considered the gold standard modality for providing primary respiratory support in a case of RDS. A meta-analysis conducted in 2016, including 10 trials with a total infant population of approximately 1,000 infants. The parameters that were studied in this meta-analysis were need for mechanical ventilation or intubation, that is failure of non-invasive ventilation, and meeting the criteria for respiratory failure. It's seen that use of NIPPV leads to reduction in need for mechanical ventilation or intubation with a risk ratio with a relative risk of 0.78, and there is also a lower risk of meeting criteria of respiratory failure with a relative risk of 0.65, both of which were statistically significant. An updated meta-analysis was published in 2021, which also included few more studies which have been published since 2016. Total infant population was 1,900. It has suggested that there is a 37% relative reduction in risk of respiratory failure with NIPPV. Coming to versus for bronchopulmonary dysplasia, the Cochrane meta-analysis conducted in 2016 has shown that there was no difference seen in BPD or death, but the latest again meta-analysis which got published in 2021 has noted that there was a significant reduction of 28% when NIPPV group was compared with the CPAP group. The risk ratio was 0.78. Coming to use of HFNC as a primary modality for respiratory distress syndrome when compared to nasal CPAP, the latest meta-analysis again published in 2021 by Hong et al. Has shown that HFNC was comparable to CPAP as a primary support for RDS and showed similar treatment rates. As we can see, the diamond is at the a point of no difference. But one has to remember that most of the studies evaluating the role of HFNC as a primary support in RDS were done in infants who are relatively larger. The total percentage of ELBW babies in the entire cohort is very low, and only 2 among the studies that were included in the meta-analysis had recruited exclusively ELBW neonates. Coming to network meta-analysis comparing various modes of NIV as a primary mode of support in respiratory distress syndrome. In this network meta-analysis, 2 outcomes were assessed. One is need for mechanical ventilation in first 7 days of life, and the second parameter was treatment failure. As we can see, only NIPPV when compared to HFNC had a significant benefit with regards to need for mechanical ventilation or treatment failure in this network meta-analysis. CPAP and HFNC again showed no particular difference with regards to treatment failure or need for mechanical ventilation. NIPPV was effective in reducing risk of mechanical ventilation when compared to HFNC and CPAP as well. And the Suprascore for NIPPV was 0.95, making it the best initial mode for respiratory support for RDS. Here, the first mode, the mode which got the highest score was NIPPV, followed by BiPAP, HFNC, and CPAP. One has to understand the limitations of network meta-analysis as well. Most of the data is extrapolated by indirect comparisons between various studies. So the role of non-invasive ventilation as respiratory support for neonates post-extubation. Coming to nasal CPAP versus NIPPV, this again is a Cochrane meta-analysis published in 2017, which included 10 trials and 1,400 infants. The grading of evidence is again moderate. So one has to understand the limitations of this reductions as well. Reduction in risk of meeting extubation failure criteria was noted when NIPPV was used when compared to CPAP with a risk ratio of 0.7 and a number needed to treat for benefit of 8 with NIPPV. Similarly, lower risk of extubation failure or intubation was noted with an RR of 0.76 and an NNTB of 10. Now comparing nasal CPAP versus HFNC in post-extubation scenarios, there was higher extubation failure rates noted in the HFNC group when compared to the nasal CPAP group. As we can see, the diamond is towards is indicating for a benefit towards the CPAP. So finally, after all the evidence, we should know what the deductions are. So there is a proposed algorithm for use of NIV and NICU. This has been this algorithm has been published in 2021 by Dr. Radha Prasad's group, published in Indian Pediatrics. Here they have categorized the neonates into 3 groups, that is low risk neonates, moderate risk neonates, and high risk neonates. Low risk neonates are neonates whose weight are greater than 1.5 kg, greater than 32 weeks, who had adequate antenatal steroid cover, and there are no risk factors for chorioamnionitis. So in this group, we can initiate respiratory support either on HFNC or CPAP based upon the experience of the unit and the ease with which the unit can deliver the non-invasive ventilation. Coming to moderate risk neonates, these are babies with a weight of 1 to 1.5 kg, gestation of 28 to 32 weeks, who have been given steroid cover, or babies who are greater than 32 weeks and greater than 1.5 kgs, but with severe distress. In this group, they have again suggested the use of CPAP as the primary mode. They have advocated against the use of HFNC and again, the use of caffeine and early risk surfactant. Early risk surfactant should be again given based on the either European guidelines or whatever the unit policy is being followed. In high risk neonates, that is babies less than 1 kilo, less than 28 weeks, need for positive pressure ventilation in delivery room, severe respiratory distress syndrome, who had no steroid cover, or there are features of maternal chorioamnionitis. In these scenarios, after initiating delivery room CPAP, one can initiate the respiratory either with CPAP or with NIPPV. The use of NIPPV in these scenarios probably would have some benefit, as we have discussed prior slides. There is reduction in need for mechanical ventilation in the first, reduction in treatment failures, and probable reduction in incidence of BPD as well. So after initiating the respiratory support, one should always continue to meticulously monitor the baby with using various objective scoring methods, that's either Downey score or Silverman-Anderson score, titrate pressures, FiO2 and flow based upon the clinical behavior of the baby, and provide adequate supportive care. And one has to escalate support and provide invasive ventilation whenever it is mandated. So coming back to the initial cases that we have discussed earlier, preterm 26 week 780 gram baby delivered by emergency LACS with respiratory distress shifted to NICU. What is the preferred mode of ventilation for this baby? So as discussed in the algorithm previously, probably an NIPPV mode of ventilation might benefit in the baby as compared to CPAP. And again, this is not a hard and fast rule. This depends upon the convenience and the convenience with which the unit can deliver this modality of ventilation. The problem with NIPPV is there should be a dedicated ventilator or device available to administer this mode of ventilation. Similarly, a preterm 26 week 720 gram baby on mechanical ventilation since birth, currently on day 4 of life and planned for extubation. What is the initial preferred mode of respiratory support for the baby? Again, probably I would consider giving NIPPV for this baby preferentially in view of the low gestation and need for mechanical ventilation for 3 days. NIPPV might help the baby in maintaining a higher mean airway pressures and improving oxygenation and maintaining greater minute ventilation. So thank you for your patient hearing. If there are any questions, I would like to take them up.
సో మేడం మళ్ళీ లింక్ తీసుకొని ఇచ్చారు. ఇందాక నేను లంచ్కి వచ్చినప్పుడు గుర్తు చేశాను మేడం. మేడం ఈరోజు సెషన్ ఏదో ఉన్నట్టుందని నాకు ఇప్పుడు కొంచెం అయిపోయింది. అప్పుడు మేడంకి గుర్తొచ్చి అవును కదా అని లింక్ వెతికి పంపించారు గ్రూప్. బయట వైజాగ్
Okay. So as there are no queries, probably we will end this stream here. Thank you all.